Good afternoon, maybe evening, colleagues and doctors. Thank you for the opportunity to present this paper today. I'm going to talk about statistical analysis of a hypothetical cohort of patients that we performed and cost effectiveness. Yesterday there was a nice discussion in Embarrassed panel about dissection and radiofrequency ablation. That's probably the future of this disease, but now we are talking about two standards of treatment. I have nothing to disclose. There is a question in whether anti-reflex surgery can affect Barrett's esophagus treatment as compared to PPI strategy. In particular, if anti-reflux surgery, laparoscopic anti-reflux surgery can be any better over medical treatment in decreasing incidence of adenocarcinoma, progression of metaplasia to dysplasia, or regression. The literature data is highly controversial on this issue. The growing literature data led to two recent large review studies. One of them was published in 2007, an analysis of surgery from the group of Blair Job. They used the strict selection criteria and came down to only one randomized prospective trial that basically was saying that there is no difference between medical treatment and surgery in terms of developing adenocarcinoma. However, there are multiple studies showing some preference and current trend towards anti-reflux surgery in terms of prevention or a decreasing rate of adenocarcinoma. Another study showed probably no difference, but this author, Professor Attila Sendis, came up with 125 patients followed for more than 10 years with very good results of his own. When it comes to clinical decision, determining an optimal treatment strategy involves assessment of morbidity, mortality, risk of esophageal carcinoma, regression, progression, or no change, cost, quality of life over the period of time. So it's not an easy decision, and probably there is no possibility to make to have some randomized control prospective study to be ever done on this issue. So the goal of our study was to define the optimal treatment strategy and cost effectiveness using decision tree analysis. We used Monte Carlo Markov model that helped us to track hypothetical cohort of patients with Barrett's esophagus for a period of 10 years. We performed a comprehensive literature review and came up with several most likely outcomes for both strategies, including regression of Barrett's esophagus, progression, no change. The patient also may develop some complication, require redo surgery in a surgical group. There's also surgical mortality to consider. Return to PPI if there's a recurrence. Esophagectomy as ultimate results of progression. We assigned utilities to each outcome. Utility is basically worth of a given health state on a scale from 0 to 1, when 0 is death and 1 is a perfect health. It is very widely used measure of quality of life, especially in recent studies. And this is the essential part of our model. We perform sensitivity analysis to assess the robustness of the model assumptions. Cost-utility analysis we decided to perform separately, but we use the same data, probabilities, and utilities. We included the cost of laparoscopic anti-reflux procedure, initial, redo procedure, esophagectomy, cost of surveillance, which is AGD with the Seattle protocol, and pathology exam for surveillance, and also daily use of PPI. We analyzed 85 published articles with a total of amount of patients about 25,000. Final utility scores for anti-reflux surgery with its 6 possible outcomes were 0.93, and the final utility score for the PPI alone strategy was 0.89, indicating that the model is favoring towards laparoscopic anti-reflux surgery over the medical treatment. Now, how we get to these results. Here you can see hypothetical cohort of patients with Barrett's esophagus, 2 treatment strategy that the hypothetical patient may undergo, 6 possible outcomes for anti-reflux surgery and 4 outcomes for PPIs. As an example, we can see progression. Let's say if somebody has a progression and would ultimately require esophagectomy, they will get the score 0.5 for the utility. Same about the PPI. Patient also may have regression that would lead to perfect health, score about 1%. Some complication may require return to PPI or reduced surgery. They receive the appropriate scores. So those scores were used many times in the literature and basically were drawn from the previous published studies. And as you can see, the final utility score, we used the 3H data software, came up with 0.93 for anti-reflux and 0.89 for PPI alone strategy. One-way sensitivity analysis was performed for each outcome, and there is only 3 examples. Progression for laparoscopic anti-reflux procedure. As you can see here, if we, let's say, we made several assumptions and how robust those assumptions were, we can see here at the given score of 0.93 for progression in anti-reflux surgery. For PPI strategy alone, in order to become a dominated or leading strategy, the progression for surgery should be about 35%. So we have a room here. This is sensitivity analysis for mortality for surgery. We know that the current literature data shows mortality from laparoscopic Nissen fundoplication is about 0.1%. Let's say if we increase, if we're wrong, and we increase the number of mortality towards about 5%, in order for PPI to become leading strategy, to become favorite strategy, mortality for laparoscopic surgery has to be about 5%. So we have the good room here also. Here is 2-way sensitivity analysis performed for both regression for laparoscopic anti-reflux surgery and PPI alone strategy, that's showing basically for the lowest value for laparoscopic anti-reflux surgery for regression about 0. In order to become leading strategy, PPI have to have a regression rate of 12.5%. At the highest score for anti-reflux, it's about 60%. In order for the PPI, in order to become a leading strategy, the regression rate has to be 75%. Finally, we performed a sensitivity analysis using the same data, cost-effectiveness analysis using the same tree, and the software came up with the scores 38.7 for laparoscopic surgery and 28.1 for PPI alone, which tell us that the PPI alone is still more cost-effective. In conclusion, our study demonstrates that the decision tree model supports preferential use of laparoscopic anti-reflux procedure for patients with Barrett's esophagus. Literature data further validates the assumption in this study based on the wide range of sensitivity tested in this model. Cost-utility analysis shows that PPI alone strategy is more cost-effective than laparoscopic anti-reflux procedure. Thank you.